Good afternoon, everyone. I'm Aaron Pollitt, the Provincial Head for Pathology and Laboratory Medicine at Cancer Care Ontario. On behalf of the Canadian Partnership Against Cancer, Cancer Care Ontario, and the Canadian Association of Pathologists, I would like to welcome everybody to today's Cancer Protocol Education Session on prostate cancer. Before we introduce our speaker and we get underway, I'd like to take care of a few housekeeping items. This is being recorded, and a link to the recording will be circulated to all participants via email when it becomes available. Both the presentation and the recorded presentation are eligible for CE credits. Information for obtaining credits can be found in the session notice. Please note, the CE certificates for each of the education sessions will only be issued for 1 month from the presentation date. Please refer to the session notice for the exact deadline. Everyone's line has been automatically muted for today's presentation. Which number of participants and will not be able to troubleshoot WebEx issues. If you're experiencing technical difficulties, please call the WebEx support line. We encourage you to submit questions at any time during the presentation using the chat feature. Chat instructions can also be found in the session notice. During the question and answer portion of the presentation, a set moderator will pose the submitted questions on your behalf for as little time permits, the order in which they appear. In the note, please include your institution name, the individual posing the question, and the question itself. It is my pleasure to introduce Dr. John Srigley. Dr. Srigley is a graduate of the University of Toronto with training in anatomic and oncologic pathology at the University of Toronto and MD Anderson Cancer Center in Houston. Dr. Srigley has practiced surgical and urological pathology for over 30 years. He is currently the Chief and Medical Director of the Program of Laboratory Medicine and Genetics at Trillium Health Partners, one of the largest community academic hospitals in Canada. He is a professor in the Department of Pathology and Molecular Medicine at McMaster and a professor in the Department of Laboratory Medicine and Pathobiology at the University of Toronto. Dr. Srigley is an international consultant and educator in surgical and urological pathology and has extensively contributed to the literature. He is the author and editor of 3 textbooks on urological pathology, including FIP Vesicle. Dr. Srigley has been an author and member of the International Working Group for the 2004 and 2016 WHO Blue Books on tumors, the urological system, and male genital organs. He is a Canadian representative of the American Joint Committee on Cancer and a member of the AJCC Male Genital System Expert Panel. He is past president of the International Society of Urological Pathologists and the Ontario Association of Pathologists. His research interests include clinical pathological and translational studies on urological cancer, population-level quality initiatives in cancer pathology, and the pathologist in cancer control. He is a founding board member and vice president of the International Collaboration on Cancer Reporting, and provided advice on population-level standardized cancer pathology reporting to the College of American Pathologists, as well as groups in Australasia, Poland, Norway, and Brazil. With ado, I'd like to introduce Dr. Srigley to today's talk on prostate cancer.
Sharon, hopefully everybody can hear me and see the presentation. Thank you very much for that very kind introduction. I thank CPAC and CCO and the Canadian Association of Pathologists for putting on this series of webinars. I think they're very useful for the Canadian pathology community. What to do today is I'd like to update everybody on the current CAP protocol for prostate cancer. First of all, I have nothing to disclose in terms of a financial conflict of interest. What I want to do today in terms of the objectives of the talk are to review the new 2017 CAP protocol for carcinoma of the prostate gland. I'm going to spend a fair amount of time talking about an update on the Gleason grading, including the concept concept of the prognostic grade groups, also referred to as the ISUP grades. I'm going to provide pertinent updates from the 2016 WHO Blue Book, which is very important for the protocol. And at the end, I'm going to talk a little bit about what's in the new AJCC TNM8 for prostate. The checklist that we're dealing with today is based on the 7th edition. And the 8th edition will be for implementation as of January the 1st, 2018. So this is the protocol. The presentation is very timely because the protocol just posted on February the 28th, and that it covers needle biopsies, TURs, suprapubic or retropubic enucleation specimens, and radical prostatectomy. The amount of content we have to talk about today, I think I'm going to focus on the needle biopsy and radical prostatectomy and not formally go through the checklists that relate to the TUR specimen or enucleation specimen. As you can see, there's a large authorship of this protocol. Ming Zhao and myself were the lead authors on this protocol, and there's a number of other well-known urological pathologists that are part of the team that put this together. We wrote the initial draft of this back in April of last year, so it's taken us from April of last year to February of this year to actually get this thing out. I have to say there was a lot of controversial issues, and some of which we actually had to do voting on. So there was some things that were problematic in the protocol, and they'll come up as we go through it, I'm sure. But I think in the end we have a very nice product that we could be proud of. Also part of the new kind of approach that CAP has in terms of the presentation of these protocols. All in the future will always be presented this way. They've made a few changes with respect to some of the definitions. So in the protocols, in America, these protocols are used for Commission on Cancer accreditation. So the mandatory elements or the core elements of the protocols are a mandatory reporting standard for accreditation for cancer centers in the U.S. And over 1,000 or I think over 1,500 cancer centers are actually accredited through the Commission on Cancer, which is part of the American College of Surgeons. So we have core data elements, and those ones that are required data elements that are essential, that are part of WHO, part of TNM staging, or that they have significant evidence base for being a prognostic factor. Those must be reported in all instances. The conditional elements are required to be reported if applicable. For instance, the total number of lymph nodes examined should be reported, but only when lymph nodes are a part of the specimen. The optional data elements are ones that do have a level of evidence associated with them in terms of reporting, but are not necessarily required for CAP accreditation purposes, but they may be useful in reporting anyways based on local practices. It should be noted that this protocol is not required for recurrent tumors or for metastatic tumors that are being resected at a different time than the primary tumor. And the protocol is also not required for pathology reviews, secondary consultations, or review of cases at secondary institutions. Further, the TURP is not considered as a definitive resection specimen, even though the entire cancer may be removed. So a protocol is recommended for clinical purposes for TURP specimens, but not for accreditation purposes. Let's now start with a little review of some of the recent advances in the Gleason system. So the Gleason system has been with us since the 1960s, and it originally started with Don Gleason's work related to patients that are part of big NIH trials and looking at the relationship between morphological patterns and outcome in those trials. And he developed a system, and you can see the diagram that relates to the system on the right-hand side, which was very successful in terms of morphologically predicting how these patients were going to do. So this Gleason system has been with us now since the mid-1960s, over 50 years. And I think it's been successful for two reasons. One, it's sort of a low-power magnification system, and so we have this very simplified drawing. So it's something that a pathologist can do in pretty quick order. You don't have to go on high power to actually make a Gleason score. Gleason grading system has been adopted by pretty all major organizations that deal with pathology and GU cancer in the world, as you can see here, including the International Society of Urological Pathology. And this goes back to as early as 2000 with the AFIP officially endorsing this in the Series 3 Vesicle. Two major events that have occurred that have altered the Gleason system. One was in 2005 and one was in 2014. So I'd like to go through some of the pertinent changes from those two consensus conferences now. First of all, the meeting in 2005 was convened basically to look at the issue of how Gleason scoring is in the modern era, especially with the thin core biopsies. So a number of very important things were decided at that meeting. First of all, the low Gleason patterns, 1 and 2, it was decided that these were not to be applied in the context of the needle biopsy, and it's quite simple because you can't really see the edge of those. You can't see the edge of those advancing nodules to really make a determination of whether or not it truly is a Gleason 3 or not. So, for all intents and purposes, the Gleason system starts at 6 when you're dealing with needle biopsies of prostate. So that was a very important observation to be made at that meeting. That's not to say you cannot see Gleason scores less than 6. And here's a nice example here, what I would refer probably as a Gleason 3, a 2+1 or a 1+2, involving the transition zone of the prostate in a TUR chip. So these things do occur, but they're certainly less common than the sort of tumors we see typically in the peripheral zone that are biopsied with the needle biopsy. Important observation that was made, or changes that were made at that consensus conference in 2005, was sort of a redefinition of where the cribriform patterns and the puiform glandular patterns, so-called Gleason 3C and 3B, should reside on a go-forward basis. It was decided that the great majority of the cribriform patterns should be put into pattern 4 based on their biology. Likewise, it was felt that the puiform glands should be also put in the band 4 category, if you will, on the Gleason diagram. So at the end of the day, at that consensus conference, the Gleason 3+3 cases in needle biopsies are cases like this, where you have single separate glands with nice, well-defined lumens. Those that have branching or complexity like this are still considered to be Gleason pattern 3. So if this was the only thing you saw, this would be a score 6. And at the end of that consensus conference, it was still allowed to consider these very small and rounded cribriform structures as part of Gleason 3. So two very nice examples in this particular photomicrograph. In this photomicrograph, which is actually taken from the consensus paper, the cribriform gland on the bottom would be considered 3 because it had a nice round edge to it, and the one at the top and the right would be considered a grade 4. So immediately when you look at this, you can see there's going to be problems with reproducibility among pathologists in trying to sort out which is 3 and which is 4 in terms of accurately giving a Gleason grade. And we'll come to this point in a minute. Glands were also put into the Gleason 4 category, and here's a very nice example here. We have a mixture of poorly-formed glands and well-formed glands in this particular example. Here's some well-formed glands here, clusters of poorly-formed glands. So this would be considered a Gleason score 7, 3+4. And in making that determination, you have to make sure that the poorly-formed glands cannot be explained purely on the basis of tangential cutting of glands that are intact. So clearly in an area like this, there's just too many present to actually be accounted for by tangential cutting. Another nice example from our International Society of Urological Pathology image database on our website, and on the top in the middle of this picture, you can see nice Gleason 3 with single separate glands with lumens, but down here you have a cluster of Gleason 4. So this would be a nice reference example of Gleason 7, and indeed all 24 consultants that saw this particular case on the web had classified it as a ISUP grade 2 or Gleason 7, 3+4. So into the consensus conference in 2005, you can see on the right-hand side, this was a modified drawing that came out of that. So most of the cribriform glands were put down in pattern 4 in the grade 4 category. There were still a few of these rounded regular structures with cribriforming that were left in the Gleason grade 3. Other things that happened at that consensus conference, some of the rules of engagement were defined. For instance, if there was a minor secondary component higher grade in a biopsy, for instance, greater than 95% 3 and less than 5% 4, the pattern 4 should be recognized. So any amount of a higher grade pattern should be recognized in that context. Contrary, though, if the minor secondary component is of lower grade, it should not be reported. So if you have greater than 95% 4 and less than 5% 3, the score is 8 in that case. Another important rule that was endorsed at the meeting was the rule related to the presence of 3 patterns in needle biopsies. If the worst pattern is not the predominant or the secondary, in other words, if there was a higher grade pattern that was the 3rd most common pattern, that the Gleason score should be generated by the predominant and the worst. So in this example, 70% 3, 25% 4, 5% 5 would be a score 8, 3 plus 5. You'd forget about the 4 in that context. It was initially proposed in the CAP protocol back in the year 2000 and endorsed at this ISUP meeting in 2005. What happened after that? Well, what happened was there was a ton of studies that came out and clinical trials were done, and what they showed based on this modified 2005 ISUP modified Gleason grading, that there was a significant upgrading effect. You can see in some of these studies where we have Gleason 6 going to 7A. 7A is a 3 plus 4, and 7B is a 4 plus 3. This 7As are going to 7Bs, 7As are going to 8 plus, and 7Bs are going to 8 plus as well. So about a third of cases were upgraded with the new system, and this was changing as well the sort of distribution of the risk classification based on the D'Amico classification shown on the lower part of the screen. So there's a significant upgrading effect related both to changes in the actual patterns and how they were placed in the Gleason grades, as well as some of the rules of engagement dealing with small volumes of higher grade patterns. During that period of time as well, after the 2005 consensus conference, there was a lot of papers that were coming out in the literature in very influential journals, Lancet, New England Journal of Medicine, etc., from clinicians and public health docs and epidemiologists related to the whole issue of overdiagnosis and overtreatment of cancer. And this related not just to prostate cancer, but breast cancer, thyroid cancer, and others as well. So there was a big pressure on the clinical communities and the pathology community related to this whole issue. One of the responses on the clinical side, of course, is the whole evolution of the active surveillance programs that we have now for prostate cancer, especially low-grade prostate cancer. And as part of that, there was since a pathologist is very much involved in active surveillance, there was a response from the College of American Pathologists and the International Society of Urological Pathologists and other groups related to our role in determining eligibility for active surveillance in the management of patients with prostate cancer. This was in response to some negative criticism that had been rendered against the pathology community at an NIH consensus conference in 2012 in Washington, D.C., at which the CAP was represented. So this came out in the Archives of Pathological Medicine in 2014 and has a lot of very good pearls in terms of how we should be approaching this from the point of view of the Gleason grading and extent measurements and other measurements that we provide in our biopsies to help guide active surveillance. So all of those things were happening in the background, so it was felt in 2013-14 that it was time actually to have another consensus conference to deal with some of the issues that had not been dealt with in the 2005 consensus conference, and to look at some of the new research that had been done during that period of time as well. So this consensus conference was held in Chicago in November in 2014, and the major paper from this consensus conference came out early last year in the American Journal of Surgical Pathology. At the consensus conference, there was 67 prostate cancer experts from 17 countries, 17 clinical leaders. The issues that were being dealt with were once again grading the cribriform glands, looking at some of the other things that had not been looked at carefully in the 2005 consensus conference, like glomeruloid glands, mucinous adenocarcinoma, intraductal carcinoma, and then to propose a new grade grouping system. Let's look through some of these things. I mentioned to you before, at the end of the 2005 consensus conference, we're still allowed to have a few cases or a few cribriform glands that had rounded edges and were very regular in Gleason grade 3. An interreproducibility study that was done revealed, in fact, that virtually no urological pathologists were including any of the cribriform glands as a Gleason grade 3 category. They were all, for practical purposes, putting them in grade 4. So based on this and other studies, it was felt that we really should move the cribriform glands, all the cribriform glands, into Gleason grade 4. And it had actually been done a little bit ahead of time by Jonathan Epstein and Peter Humphrey in the 2011 series Prostate Vesicle from the AFIP. And their diagram has the proposed new diagram on the far right-hand side has absolutely no cribriform structures in the Gleason Grade 3 category. Well, this was endorsed at the 2014 Consensus Conference in Chicago by more than 95%. Also determined that when you have a glomeruloid pattern, like is illustrated in this particular picture, that should be considered also Gleason Pattern 4, in addition to the typical cribriform structures that one sees. So in Gleason Pattern 4, there's basically 4 patterns that one sees. One sees the cribriform structures, fused glands, poorly formed glands, and less commonly these glomeruloid glands. Mucinous carcinoma was also discussed at the 2014 Consensus Conference, and it was decided that the grading should be done by subtracting away the mucin in one's mind's eye and looking at the underlying patterns, which often would be either 3-3 or sometimes 3-4, 4-3, or occasionally 4-4, but basically to subtract away the mucin and try to judge the underlying architecture of the glandular proliferation. Ductal carcinoma was a big issue because from 2005 onwards, there had been a ton of publications related to intraductal carcinoma, and it was emerging as a very important topic. Clearly, the process of intraductal carcinoma was being identified as a significant adverse prognostic factor in various series related to biopsies and radical prostatectomies. The problem is that should it be graded or not graded? And it was decided at the Consensus Conference that the intraductal carcinoma should not be graded. This is from the point of view of practical outcomes. It's important because usually when you see intraductal carcinoma, it's in the context of higher stage, high volume, and high grade disease, invasive disease, and it's not much of an issue. In that situation, it's not a problem. It can be a problem, of course, if you have a Gleason score 6-3 and you have a few glands that are involved by intraductal carcinoma. What do you do in that situation? Well, the important thing is to recognize the adverse prognosis associated with intraductal carcinoma, and a patient that would have a Gleason 3-3 with IDC would certainly not be eligible for active surveillance. Likewise, very rarely you just see pure IDC without any evidence of invasive disease elsewhere. And in those situations, those cases should be followed up fairly quickly, and additional biopsies should be undertaken. There's even some people that feel that with the presence of IDC, even without invasive disease, that the patient should be treated up front. So basically at the Consensus Conference, we decided that no, you should not be grading intraductal carcinoma. And at the end of the Consensus Conference, we came up with a new diagram, which is the official ISUP WHO diagram for Gleason grading, which has the basically, once again, 5 grades. In grade 3, you can see that this has been expanded to include some of the patterns that one sees with prostate cancer, like the atrophic pattern, the pseudohyperplastic pattern, the microcystic or cystic patterns, that the cribriform structures are down in Gleason 4. Some of the more solid ones with commuter necrosis are down in 5, and the poorly formed glands have been pushed down into Gleason 4. But once again, you can see that there is this threshold between these small glands up in pattern 3 and the poorly formed glands in pattern 4. This has been published now and is included in the WHO Blue Book 2016. Now, the rationale for going ahead with a new grading system or a grade grouping system from a number of different reasons. One was because of the whole issue with the Gleason grading scale. As I said, the scale essentially starts at 6 for needle biopsies. So basically 2 to 5 don't exist in the biopsy situation. So this presents some problems for patients because they go on the internet and they see the Gleason system is going from 2 to 10, and they see that their Gleason score is 6, and they think they're somewhere in the middle, not realizing in fact the Gleason 6 is the lowest that one could have in the needle biopsy. So it's not really patient-centric. The other issue was that investigators and researchers were doing inaccurate grade combinations for big clinical trial purposes. For instance, they were grouping things like Gleason 2 to 4 as being low grade, 5 5 to 7 as intermediate grade and 8 to 10 as high grade, and not recognizing the fact that the low Gleason score should not even be included in that sort of system. So there was problems with using inaccurate grade combinations, and furthermore there was this issue of Gleason 6 not being cancer, and why are we calling it Gleason 6? If it has such a indolent biology. So those are the sort of the problems that we came up with. Now the grade group system that's been developed at the 2014 consensus meeting is not particularly revolutionary. It's sort of highly evolutionary. You can see here just a number of the grouping systems that have been used over the years, over the many years for Gleason scores, and the one at the bottom is the one that was endorsed at the SUP meeting in 2014, where we have 2 to 6 as 1, 3 plus 4 as 2, 4 plus 3 is 3, 8 as 4, and 9 to 10 as 5. And this was initially published in 2012 in a paper with Epstein and Parton, and it was basically for the new Parton tables that were coming out of the Johns Hopkins hospital. And this is additional data from Johns Hopkins on a large data set of over 2,000 cases, looking at over 5,000 cases, looking at the Kaplan-Meyers for these various grade groups, showing fairly nice split, although between 4-3 and 4-4, in other words, grade group 3 and 4, there's not a lot of difference. There was also a large evaluation study that was done looking at pooled data from 5 different institutions over 20,000, close to 20,000 cases, and their Kaplan-Meier curves were really quite nice in terms of the separation of those groups. So it had some very science behind it. The grade grouping system is shown here. So 6 or less would be 1, 7, 3 plus 4 is 2, 4 plus 3 is 3, 8 is 4, and 9 to 10 is 5. There was controversy from the outset about what the CLIS grading system and the sort of official group has been used in the CAP checklist and the WHO Blue Book. ISUP grade is something that's also used, and there's at least 10 papers that are published in the literature now where the word ISUP grade has been used as a synonym for grade group. So you see both in the literature. And this has been endorsed by the ISUP and also the WHO for use in both biopsies and radical prostatectomies. So the advantages to the new system: it has more accurate stratification in the current system, lower number of categories, and I think probably the most important thing is that it's quite patient-centric, and the lowest grade is 1 and not 6, which is very useful, I think, for discussing treatments with patients. 90% of the participants at the ISUP consensus conference said yes, and it was accepted by the WHO. And for the time being, it should be used in conjunction with the Gleason system, so it should be reported as Gleason score 3 plus 3 equals 6, or 6 brackets 3, 3, ISUP grade 1 or grade group 1. So the recommendations that came out of the consensus conference is that a report a Gleason score on all newly diagnosed cancers, report the grades or patterns with the score to make it clear what is present. For instance, Gleason score 7, 3 plus 4, or 3 plus 4 equals 7. Report the ISUP grade or the grade group as well. And another recommendation that came out was to report the percent grade 4 for Gleason score 7 cases. That was a recommendation from 2015 ISUP and the 2016 WHO, and I'll come back to that point in a moment. So let's now move to the meat of the checklist, as you can see here. The checklist is for biopsies. We'll do the biopsies first, then we'll hit the radical prostatectomies. The biopsy just have been split into two different ones. One is a specimen level summary, and the second one is a case level summary. And we'll come back to the case level summary in a minute. But the specimen level summary is the one we're going to focus on because from the point of view of the College of American Pathologists, that the minimum level of reporting for the prostate cancer and Gleason scoring should be at the specimen level. From the point of view of the WHO and the ISUP, the is that the reporting and the Gleason scoring should be done at the core level for every separately identified core. In other words, if you have a core we have a single core submission in one container, that one core, that core equals a specimen and should be reported at the specimen level, which is the level for that type of case. If you have a specimen that has 6 cores in it, you're not obliged to render a report on each one of those cores in that situation, unless they've been separately identified by some kind of inking technique, which some people do, which is quite uncommon. So in a specimen that has more than one core, the minimum level from CAP's perspective is at the specimen level, and you can have more granular reporting if you want to yourself at your local level. But from the point of view of what would be considered required, it would be at the specimen level. So you can think about, and it's very nice, if you read explanatory note A, it goes into all those details regarding reporting at core, specimen, and at the case level. So the first thing one reports, of course, is the histological type of the cancer. And the majority of these are just adenocarcinomas, Asner type, or not otherwise specified. And because there's a number of other patterns that one can see, we didn't put all those different categories in that sort of field. We just left other specified. So the other specify is basically taken out of the WHO Blue Book, and you can see some of the categories in there that one sees: atrophic, pseudohyperplastic, microcystic, foamy gland, mucinous, signet ring-like, pleomorphic giant cell, sarcomatoid. Some of these are much more common than others, but all of them are not that common. But if you want to, you can include those patterns in there under other specify if you prefer. Likewise, ductal adenocarcinoma. I think ductal on its own is fine, but some people do try to split them down into categories such as cribriform, papillary, solid, and the neuroendocrine tumors. Be reported using the checklist if there's an adenocarcinoma component. So in the neuroendocrine tumors, you have adenocarcinoma with neuroendocrine differentiation, either identified by Pannis cell-like change or by IHC, and that would be reported under this checklist. As well, you can have combinations of adenocarcinoma and small cell or large cell undifferentiated carcinoma. You can use the checklist for those. I don't think the checklist would necessarily apply if you have a pure small cell or large cell neuroendocrine carcinoma, although it would be very uncommon for that sort of case to actually get to certainly to a resection specimen. But I mean, in that situation, that's a completely different disease that needs to be approached with upfront chemotherapy. With respect to the next element, of course, after histological type is the Gleason grade. So what you report the primary pattern. You can see there's only 3 listed now. Before there was 5 listed in the previous checklist, and the worst remaining. So when there's 3 patterns present, we use the predominant pattern and the worst remaining pattern. Obviously, if there's 2 patterns present, you put both of them down, and then you arrive at a Gleason score. So all those are considered required elements from the point of view of this checklist. And then, as well, you assign a grade group to the specimen based on the criteria that I alluded to before. Grade group 1 is 6, 2, 3 plus 4, 7, 3 plus 4, 3 is 7, 4 plus 3. Grade group 4 would be Gleason 8, and grade group 5 is 9 to 10. Let me come to the next issue, too, that I alluded to before, and that is the percentage of pattern 4 and Gleason score 7 cases. So this was something that was recommended at in the consensus conference, ISUP consensus conference. It was something that the clinicians really wanted, and it was endorsed in WHO Blue Book as well. From the point of view of writing this checklist, we felt that this was really only something that may be required in the situation where you have a Gleason 7 3 plus 4 tumor, that you try to give some estimate of the percentage of pattern 4. And the reason why is shown on the next slide. On top, we have the Cancer Ontario published a guideline on active surveillance for localized prostate cancer back in 2005, and this was, I thought it was a very well done guideline through the Program of Evidence-Based Care. And the the ASCO in the U.S. actually felt that this was very well done. They didn't want to do it again, so they actually endorsed the CCO guideline. So now it's accepted as a North American standard. And in that particular guideline, though the of cases of active surveillance are Gleason 633. It allows for consideration of patients that have low volumes of pattern 4. So the Gleason 7/3+4 with less than or equal to 10% pattern 4 can still be considered for active surveillance according to the recommendations of this guideline. So that's one of the main reasons why we felt it was important to include that parameter in the checklist. So as to how to do that from a practical perspective, can be challenging, but I think it's important to at least have some sort of bins to put this into. So I think less than 5% is a traditional bin for a more high-grade element, or in 6 to 10%. Then after that, you can either go 10, 20, 20 to 30, that sort of way of doing it, or you can go 10 to 25 and 26 to 50. It really depends on your local practice. Really no specific recommendations that are out there. So it's at this point in time, I think there's more data coming out on that, and I think eventually we will have some more strong recommendations. So really, I think at the we record it as in 10% intervals, with the exception of those when you have very small amounts of tumor, less than 5% or 6 to 10%, because that's important with respect to the surveillance protocols. In the checklist, we also included a optional. The little star here means optional. Percent of Gleason patterns 4+5 when you're dealing with Gleason scores greater than or equal to 7. So 7, 4+3 and above, it's optional to include the percentage of pattern 4 and percentage of pattern 5. In my own practice, I've been including the percentage of pattern 4+5 for many years, and it's found, and I think the urologists find it very useful, and the oncologists find it very useful in terms of their treatment planning. Ductal carcinoma is an optional element, but one I think that's maybe evolving from optional to more of a core element as we get more and more data, and it's sort of recommended that you include ductal carcinoma, although once again it's optional, it's not a mandatory requirement. Now, the important aspect of the core biopsies is measurements of tumor extent. And this really hasn't changed from the prior prostate biopsy protocol. It's virtually the same field that we put in here. So the quantitation should be done in two different ways. So you do a core count, number of cores over positive cores, and also a percentage of the percentage of the tissue involved by tumor in terms of linear millimeters or linear extent of involvement, or actually linear millimeters of involvement. So the core counting plus extent as percent, or core counting as millimeters actually measured, or if you want to do all three, that's an option as well, but I don't think very many people do all three. In my own practice, I do the first one, so I do the core counting and percentage of cores involved and percent of tissue involved by tumor. However, in a situation where I have a minimal cancer, a tiny focus with one site involved, I usually also include a linear millimeter measurement just to indicate to the urologist how tiny the tumor is in the specimen. No matter which way you look at tumor extent, there's a number of papers out there showing that it's a very powerful predictor in terms of PSA failure, and this is from a paper by Fatty Bremo, Histopathology, back in 2008, looking at a number of different types, different ways of measuring extent, percent positive cores, greatest percent cancer in any one core, total percent cancer, total millimeters, greatest millimeter of cancer, or millimeters of high-grade cancer. Look how significant that one is. So there's a number of studies out there showing that this is a very important measure to include in our reports, and that's why it's considered as a required element. There are, however, lots of problems with measuring extent in needle biopsies. And these were a nice reference on this. This is a reference from archives of the active surveillance paper that I alluded to earlier at the beginning of the talk in 2014. There's a whole section in there on dealing with measurements of extent in needle biopsies. And there's problems here with measuring discontinuous foci that I'll come to in a moment. There's problems when you have core fragmentation. When a tissue is heavily fragmented, you can't really get an accurate core count or core percentage. Inadequate sectioning, when you don't have a complete representation of the core, that's a problem. Inadequate core length, what is the minimum amount of tissue that one would need? And also whether the core length should include extraprostatic tissues or not. So all of those sort of things are problems in terms of interpreting these sort of specimens. Let me show this example from a very practical practical perspective. So here we have a patient that's being considered for active surveillance. And a lot of the active surveillance protocols, they want to have a patient that has, a Gleason 6 and three or less cores involved by tumor, and no core involvement greater than 50%. So you can see this is going to be a problem already. All three cores are involved. The left lateral base, left medial base, left lateral mid are all involved by a Gleason 3-3, and you can see one core is 40%, one core is 20%, but this one core here, we have 5% at each end, so that it's 10% actually involved by tumor, but what do you do about the discontinuous stuff in the middle? So if you include the discontinuous stuff and say it's 100% involved in a discontinuous fashion, the patient's not eligible for active surveillance. But if you say that it's only involved by 10%, then the patient is involved by is eligible for active surveillance. So that's a big problem with these prostate biopsies. There's no problem with that top bar. That's 100% continuous involvement. I think the middle bar, when I see something like that, I just call it 100% involved, realizing that the tumor is probably just weaving in and out of some of the structures. The one on the bottom, however, is the real problem. So I think when you do have a situation like this in a patient where where it's going to make a meaningful effect on treatment decision, i.e. active surveillance or not, it's probably better to have a little comment saying that while the tumor is only involving about 10% of the actual linear extent of that core, it does go from end to end, and therefore it's 100% discontinuous involvement by that criteria. So make a comment saying that both of those things are going on in the case. I think that's worthwhile. Now, what does the literature tell us? Well, the initial paper from Hopkins suggested that taking into account the intervening uninvolved prostate was a more accurate way of predicting for adverse pathology on radical prostatectomies. In this study here from the group in Henry Ford, they found when they did very detailed mapping between the biopsies and the radical prostatectomies that in about 3/4 of the cases, it was the same lesion. It was just sort of being represented sort of in an irregular fashion in the prostate cores. However, in about 20% of cases, 55% of cases, they were two separate lesions. And in another study where they used more of a IHC molecular approach to it, looking at different sort of clonal markers, it was basically the same thing. Roughly about 3/4 of the tumors, when you see this discontinuous pattern, it represents the same tumor, but in about 1/4 of the cases, they're two separate tumors. Moving on now, the other things to include in when you're looking at core biopsies of prostate are the elements that are also important. For instance, is there periprostatic fat involvement? In my own series of cases, that's about 3%, which is actually very close to another series from Dan Burney's group that I saw at the USAP this year, which is also about 3%. So for the CAP protocol, it is really considered as a conditional element, document if identified. And what the CAP is trying to do is trying to get rid of a lot of these situations have these low frequency events and not having to put down not identified. So the not identified is an optional. If it's present, it's required, but if it's not identified, it's optional. And that's just basically to clean up the report a bit in terms of the amount of information in it. And the same with seminal vesicle or ejaculatory duct invasions. Seminal vesicle invasion is very difficult sometimes to separate from ejaculatory duct involvement, and in my reports I often just say involvement of seminal vesicle / ejaculatory duct tissue. And it really only makes a difference when you know it's seminal vesicle. So if you have a directed biopsy of seminal vesicle, I think that's important to sort of document involved in that situation, because that would be indicating to the surgeon that you're dealing with a stage PT3B situation. Lymphovascular invasion, this is considered optional. I mean, you see it very rarely, and in my experience, it's virtually always in high-grade and extensive disease. And parallel invasion is controversial as well. I think in some studies, at least in univariate analysis, it has some very correlation with outcome, whereas in multivariate analysis, especially if you have the extent measurements, it's not as important. So this is a little bit controversial, but for the purpose of the checklist, these are considered optional elements. I do include this in all my reports in my own practice, though. Some nice examples here of perineural invasion shown on the left and the right-hand side. Is a nice example of invasion into periprostatic fat. So when you see this, I think you're indicating to the in your report, you're indicating to the urologist or the oncologist that the tumor is at least stage or at least category PT3A in terms of the local extent. And I think that is useful information for them to have in their treatment planning. The additional pathological findings, these are all optional elements, i.e. high-grade PIN is optional, adenosis, atypical adenoma, hyperplasia, inflammation, so they're really not that important. If you want to include things like PIN, that's fine, but it's not mandatory. Let's move on to the biopsy, the case level summary. So this is new for this protocol, and it's considered optional. It's sort of put out there for people to try and to use, but it's not mandatory for accreditation purposes or any other purposes. So the whole checklist is considered optional. But this is an important one because I think the prostate biopsy reports are getting so complex now. And if you do a case summary, a structured case summary for every positive specimen, sometimes you could have 12 positive specimens, you could end up with having 3 or 4 pages of information for the urologist or the oncologist to digest, whereas a case level summary puts all of this information in one field at the beginning, usually at the beginning of the report. So I think it's quite useful from the point of view of writer centricity in terms of having a nice looking report that's easily digestible. Now, if you use a case level summary, all you need to do for the specimen level reporting is to have a simple macro that includes, the adenocarcinoma, the Gleason, and the extent measurements as a one-liner, and all the information from that's gleaned from the synopsis of everything is put actually at the case level. And I think a lot of people in Canada are reporting that way. Not everybody, but a lot of people are reporting that fashion. So once again, I won't dwell on all the individual things. Obviously, the histological type. Now, Gleason score. This is interesting here because when you're reporting at the case level and you have a diversity of Gleason scores, I think it's important to identify the Gleason score that represents the highest Gleason score in that synopsis or that case summary at the beginning. So that's one field I think that's very important, to have the highest Gleason score and what the primary pattern and secondary pattern is, and it can specify where that site is of involvement as well. And then you have a grade group that's determined by the highest Gleason score, and you also can have the percentage of pattern 4 represented here as well, and the percentage of pattern 4 and 5 for cases that are greater than or equal to 7, 4 plus 3. So we have the pattern 4 and the 3 plus 4s, and the 4 and 5 in the greater than or equal to 7, 4 plus 3 or above. Now, I'll show you this case. This is where I think we run into some problems. So here's a case here where we have 12 core sampling in 12 jars. We have 3 different sites involved, so lateral base on the left, medial base on the left, and lateral mid on the left. And we have a 3-3, a 4-4, and a 7-3-4. So if you look at this, the highest Gleason score in this case is an 8-4-4. So a lot of clinicians would take that as the Gleason score for treatment purposes, even though it's only about 5% involved in that case. Whereas up here we have a lot of tumor in a 3-3 in the left base. Here we have a mixture of the 7-3-4 with more 3 than 4. And you can see from looking at that, knowing sort of distribution of tumor from the topography, that this is probably all one tumor if those 3 kind of adjacent sites are all involved. So from the point of view of the highest Gleason score here, it's an 8-4-4, but if you were going to do a composite or a correlated or an overall Gleason score in this case, and just looking at what we have here, you'd be predicting that in the radical prostatectomy, you're going to end up with a 7-3-4. So that's what we mean by a composite Gleason score. So in that situation where you have that kind of diversity and you have one area with a small amount of higher grade tumor, you can also include a composite Gleason score and include in that situation, so the primary in that situation would be 3 and the secondary would be 4, and the grade group would be 2. So you can see there's a significant difference in the grade group that's generated by the composite Gleason score versus the one by the highest Gleason score in that case. In my own practice for the last 15 years, I've been doing a similar thing. I've been including sort of an overall or correlated Gleason score, highest Gleason score when there is that diversity, the highest Gleason score, and so percentage 4 or 5. So this immediately gives the urologist an indication, well, the highest Gleason score is 8, that the overall amount of percent 4 or 5 in that case is low, and from the point of view of trying to predict what the radical prostatectomy Gleason score is going to be, it's going to be likely 7, 3, 4. The very nice paper came out a couple years ago in the American Journal of Surgical Pathology from the group at Henry Ford in Detroit, and they actually looked at this whole issue of diversity of Gleason scoring and topographic distribution of tumor and needle biopsy specimens, and they showed in their paper that the composite Gleason score was actually more accurate in predicting the Gleason score in the radical prostatectomy specimens. You see, there's lots of controversial issues. For biopsies, should the ISUP grade or the prognostic group be assigned at the core specimen and case level? I personally feel that if you're doing a case level summary and you just have a line level diagnosis or a one-line diagnosis for each of your positive specimens, that having the ISUP grade or the prognostic grade group in the case summary is fine. You don't have to have it in each of the individual lines. We've already talked about the problems with stratifying percent 4. I think as long as you recognize the situations where the small amounts of 4 less than 5 or 6 to 10%, that's what's very important from the point of view of a patient being eligible for active surveillance. And is there a role for reporting percent high-grade patterns 4 and 5 in the Gleason 8 and 10 tumors? I think there is, but it's optional from the point of view of this checklist. Now, some of the other issues with Gleason is, do minor high-grade patterns, less than 5% or so-called tertiary patterns, affect assignment of Gleason ISUP grade for radical prostatectomy specimens? How to deal with non-minor tertiary patterns in radical prostatectomies, and in radical prostatectomies, Gleason grading of dominant nodules versus global score. Those are important issues. So let's turn now to the radical prostatectomy data set, or the checklist. So one of the things with the radical prostatectomies that's important is you have to decide how you're going to be submitting these. So in my laboratory, we submit the whole gland, unless the gland is 100 cc's or 80 cc's and above. What we do in those situations is usually get rid of some of the BPH material in the middle and just put all the periphery through. But I think that we certainly are big advocates of total gland submission in this organization. It certainly gives you a much better representation of the distribution of tumors, whether or not there's a dominant tumor or not, dominant nodule or not. I think if you are going to do partial sampling, you should do it in a very systematic fashion, and the recommendation that a lot of people use is that they would put the posterior blocks of the radical prostatectomy, so the whole sort of peripheral zone at lateral posterior is represented, and they might take sort of the anterior middle sections through the midgland here in this region here, and then submit as well through a junction of the base and the seminal vesicle on both sides. I think the actual margins from the base and the apex should be put through in total. So you can reduce the number of blocks in doing it that fashion, probably by about 20% or maybe 30% in some cases. But I think the total gland submission is the ideal way of doing it. So, view of the radical prostatectomy. Radical prostatectomy. We can include a weight and size, although this is now considered optional, although in the previous checklist the weight was considered mandatory. This was something that was voted on, and we decided to actually keep it as an optional element. Obviously, same as the biopsies, adenocarcinoma, NOS, or other. If it's other, you specify the other type of adenocarcinoma. The Gleason scoring is a little bit different with the radical prostatectomy. So in the radical prostatectomy, we actually record the presence of the 3 patterns. So the pattern here, now we've included actually 1 through 5, because really you do get patterns 1 and 5 in the transition zone. So for the primary elements 1 to 5 and the secondary elements 1 to 5, we also have a category for tertiary pattern down here, which was also in the previous CAP checklist for the radical prostatectomy. And it's important to read this note at the bottom. If 3 patterns are present, record the most dominant and the second most common pattern. So that's how we define primary and secondary in this situation, and not the and the highest or worst as you do in the biopsies. The tree pattern should be recorded if higher than the primary or secondary patterns, but not incorporated into the Gleason score if it's less than 5%. So if it's a minor amount, it's not included in the Gleason score. If it's a non-minor amount, there really isn't a huge amount of guidance in the literature on this, and some authors actually do include that tertiary pattern in the Gleason score, especially if it sort of gets up in a significant range. So in other words, if you have a Gleason prostatectomy that's 50% 3 and 30% 4 and 20% 5. Some people would record that as 3, 4, tertiary 5 with 20% pattern 5 somewhere in their report. Others would record it as a Gleason score 8, 3 plus 5. There really isn't a huge amount of guidance in the literature on making that decision, and hopefully there will be over the next few years with more studies that are being done. And as well, of course, in addition, once you have your Gleason score, you want to do your grade group assignment or your ISUP grade assignment. You can see here 1 through 5, just like you did with the biopsies. And we want an optional element here, of course, is the percent 4 and the percent 5 in that case, which is very helpful, especially if you have 3 patterns present, as I alluded to before. Once again, the presence or absence of intraductal carcinoma is considered an optional element. In terms of tumor quantitation, at the very least, you want to have some indication of the percentage that's involved by cancer, and this is just considered as a ballpark or an eyeball type measurement. And some people look at things such as less than 1%, 5%, 5 to 10%, then go into percent intervals after that, and it really is an eyeball measurement. If you do identify grossly a dominant nodule, however, you can put a greatest dimension of that nodule in this field in the synoptic report, and the additional elements would be considered optional as well. So you can give nice two-dimensional measurements in a case like that. Here's a nice example here where we have a dominant nodule. And that was the only nodule that was present in this case. It was a dominant nodule of high-grade cancer. And in this situation, you have multiple foci of cancer. So this begs the question of how do you Gleason score these cases as well, and the importance of the dominant nodule. So one of the problems with the concept of a dominant or index nodule is that it's not really well defined. Is it the nodule that's the greatest diameter, the greatest volume? Is it the nodule that's the highest grade? Is it the nodule that is highest stage in terms of extent? And I think in most cases one can identify a dominant nodule. Perhaps 50 to 75% of cases one can identify a dominant nodule. In cases where you can't, I think it's better just to sort of do a mental calculation in your mind of all the involved foci of adenocarcinoma. However, when you do have a distinct nodule, it's worthwhile reporting that. And the important thing not to do is if you have a nodule that is a Gleason 844, and you have, say, another nodule that's a separate nodule that's a Gleason 633, not to average them out, to actually identify that one nodule with the higher grade and report it separately. So it's a little bit confusing on some of these reports, and sometimes you end up having to sort of identify, well, nodule 1 has this Gleason score and this extent involvement, and nodule 2 has another one. So often in those situations, you might have to have a clinical pathological comment that would take into account those complexities. Prostatic extension, of course, is very important to document in the radical prostatectomy specimens, and that's reported as both its presence or absence, and also the whether or not it's focal versus a non-focal. So a focally present EPE means that's a very small amount of EPE that's just getting out and involving fat in less than 1 hyperfield in 1 or 2 sections. Anything more than that is called non-focal. It's an important observation to make, as well as whether or not there's bladder neck invasion and seminal vesicle invasion. So the PT3A in the TNM staging system, that's where you have extraprostatic extension, and that can be either unilateral or bilateral. So here's this example of extraprostatic extension where we have tumor that's getting well into the fat out into that fat plane, and it's quite clear this tongue of tumor is just coming right out through the middle of that site. Likewise, here there's tumor that's involving fat that's beyond the sort of interface between the prostate tissue on the right and the extraprostatic tissue on the left. So those are nice examples of EPE. Sometimes you don't actually see fat, but you see a bulging nodule, which may or may not be associated with desmoplasia. And here's a very nice example here of that bulging nodule criteria for extraprostatic extension. This is from one paper showing the importance of trying to quantitate whether or not it's just focal or extensive. Here we have negative focal or extensive by survival, showing that the extensive EP is more significant. So this is what I mean by focal EPE, where we have this tiny little focus of tumor here that's sort of in this plane, getting out here just on that plane where the fat is, so that would be considered as focal EPE, in contrast to this one here, which is well-established or non-focal EPE. The bladder neck involvement is important. So if the bladder neck is grossly involved, if the urologist on cystoscopy identifies it as involved or on physical examination is involved in this fashion, it's considered PT4. But this is actually relatively uncommon for us to see this sort of extensive involvement of the bladder neck. More commonly what we see is this, where we take our sections from the base of the bladder neck region and we see tumor that's involving some of these large muscle bundles that you can see in this slide here, the intersecting between the muscle bundles. So this, it was in one of the earlier versions of, I think it was TM6, this was still considered stage PT4, but the publications that have come out over the last decade have indicated, in fact, that these sort of tumors behave more like stage PT3, so this should be considered as equivalent to a PT3 or extraprostatic extension in terms of its significance. So that's included as an element in the radical prostatectomy checklist. Likewise, seminal vesicle involvement is very important because that defines stage PT3B, and there's at least 4 different ways of seminal vesicle to be involved, and this is a classic diagram from Tom Wheeler's group at Baylor looking at this phenomenon. You can have tumor that's coming up the ejaculatory ducts into the seminal vesicle that way. You can have tumor that's invading directly into seminal vesicle. Very commonly I see is tumor comes out into the periprostatic fat and then sort of comes back and infiltrates into the wall of the seminal vesicle, like this area over here. That would be the type 2B. The discontinuous one, it really essentially is sort of almost like a local metastatic disease, if you will, or a vascular type spread of the tumor within the seminal vesicles. That's relatively uncommon. Definitions of what we mean by seminal vesicle involvement is you have to have invasion of the muscle coat of the seminal vesicle, as shown very nicely in this slide, and also in this slide as well, with seminal vesicle epithelium in the bottom and the cancer infiltrating the muscle coat at the top. Margins are important to record in the radical prostatectomy specimen. So the important aspects of margin positivity are margins involved or not, and also what is the extent of involvement and what is the site of involvement. So what was recommended from the ISUP consensus conference it was published back in 2011, that not only do you record whether or not the margin is involved, but also what degree of involvement it is, and a cutoff that's been used frequently is less than 3 millimeters or greater than or equal to 3 millimeters, and also the various standardized sites of involvement, so apex, bladder neck, anterior, lateral, posterolateral, posterior, or other. The other sort of whether the sightedness of the involvement or other measurements here where you have this little cross are considered optional in terms of their reporting. So by definition, for margin involvement, we have tumor that's reaching the inked surface, as you can see here in this picture, so that would be margin involvement. There's a couple of very important aspects that have been recent developments in margin positivity issues, and if you look at these checklist elements, margin positivity in areas of extraprostatic extension and Gleason pattern at positive margin, these 2 elements were not included in the previous version of this checklist, so this is more new information. So what we mean by the margin positivity in the area of extraprostatic extension is shown here. And this gets at the whole issue of capsular incision, or the so-called PT2M+ situation. So in this diagram, we have the prostate gland with the white circles being the prostate glands, the red circles being the cancer. This would be the edge of the prostate gland. This crosshatched area here is the periprostatic tissue. So if you have a tumor that's PT3AM+, it's going out into the fat, into the surrounding tissue, and touching the ink. And it indicates that these ones are particularly aggressive in terms of their biology. PT3AM negative is shown here, where we have the tumor going out into the fat, but it's not reaching the ink. PT2M minus is we have a tumor that's confined to the prostate, and it's not touching any ink. Then on this side, we have the PT2 plus situation. So either you have this divot situation where you have a gap in the gland where you're not really sure what's going on, whether this was a PT3A or a PT2 to begin with, but you just have this divot and you see cancerous glands and normal glands along the ink. So that's the sort of classic PT2 or incision. But more commonly, you see the one on the right-hand side over here. So you don't have any extraprostatic tissue, and you have this sort of rounded edge with ink on it. You have the tumor coming right up against it. So this, in my experience, is more commonly seen as PT2+. So that's the sort of thing that one has to deal with. And in the prior iteration of the checklist, by cancer case summary, you were never sure whether or not the margin positivity was at the area of extraprostatic extension or not. So unless you have this data element in there, you're not going to be able to make that observation, because you could have margin positivity that's PT2 plus over here, and then you could have a PT3A margin negative here. So that situation is a much better situation to be in than this situation over here. We have PT3AM+. So the only way of capturing that was to include this data element in the checklist. Now, what about Gleason pattern? There's been a number of papers. Well, first of all, before we get to that, here's just some examples here. We have a PT2 margin negative, so the tumor is still within the prostate, and you can see extraprostatic tissue, and the margin is clearly negative there. Here's a nice example of that capsular incision here. So we have the ink is at the tumor is at the ink, and there's no extraprostatic tissue beyond that, so that's PT2M+. Here's an example of PT3A margin positive here, where we have the tumor actually getting out to the ink, and it's actually beyond the fat, or it's involving the fat, so it indicates that we're dealing with a PT3 situation, margin positivity. And another example here. Once again, the Gleason grade at the positive margin, there's a number of papers now showing that the higher grade patterns when they're at the margin are more significant and are predictors of adverse outcome, especially when you get patterns 4 and 5, like you see here at the margin. So that's been included in that in the new checklist as well. Additionally, other things to include would be whether or not there's a treatment effect or not. Lymphovascular space invasion is an optional element. Perineural invasion is an optional element. Perineural invasion I don't record. I mean, it's so common in these specimens. Lymphovascular space invasion I do record. Here's a nice example here of LVI in a radical prostatectomy specimen. However, the prognostic value of this is controversial, because if you take into account other parameters, it tends to follow as a significant prognostic factor in some of the multivariate analysis, and it's just an important prognostic factor. I certainly include it if I see it in my radical prostatectomy reports. Perineural invasion, not so much. And just a little bit about lymph nodes. Once again, we want to record the number of lymph nodes involved, the number of examined, and optionally you can put in the sites of involvement, because I know there has been a movement to more extensive lymph node dissections. The diameters of the largest metastatic deposit and extranodal extension are considered as optional elements. Final stage of the tumor. This checks is based on the TNM7 staging system from AJCC. So in the TNM7 staging system, we have the PT, the classical P staging starts at PT2. There's no PT1 staging. It doesn't exist. So that's PT1, or T1 is only defined for clinical stage. So it starts at PT2, and in the classical one, it was PT2A was unilateral, less than one-half of one side. 2B, more than half of one side, and 2C, bilateral disease. 3A is extraprostatic extension. 3B is seminal vesicle invasion, and T4 is invasion of rectum, levator muscles, and/or pelvic wall. So that's what is in the TNM7. We actually, on the last checklist, put this note in here. There is no pathological T1. Subdivision of PT2 is problematic and has not been proven to be of prognostic significance. So we were anticipating a change in the TNM for the 8th edition, and this has been in there actually since about 2012 after the ISUP consensus conference. So the issue is this. So this would be T2A less than 1/2 T2B. The problem with pathological T2C is that it can be either one of these situations. It could be a large tumor involving both sides of the gland, or it could have two microfoci of Gleason 633, which would also, by this definition, be considered as a PT2C. So that doesn't make a whole lot of sense. There wasn't much data in the literature really to support separation of PT2 at a pathological level. So from the point of view of the AJCC update, which is shown here, this is the for implementation in January 1st, 2018. So all the CAP checklists, including this prostate one, will be re-released with the with the TNM8 updates in it. But I just wanted to draw your attention to this table on the bottom because it really in a lot of updates with respect to prostate. So the big update I just went over with you, and that is pathologically organ-confined disease is considered PT2 and no longer subclassified by extent of involvement or laterality. So we don't have that A, B, and C anymore. And so the Gleason score and grade group should be reported. We've already gone over that. That's already included in this update. And stage 3, which is stage group 3, includes selected organ-confined disease tumors based on PSA and Gleason and grade group status, and not just on anatomic extended disease. So that was a departure from before. So just to summarize, for the TNM8, at the clinical level, you still have PT2 substaging. So this would be clinical stage T2A and T2B respectively, based on whether or not it's less than or equal to half of a site of the prostate involved. This would be T2C based on DRE findings. So that's at a clinical level. But at a pathological level, you can see there's only PT2 organ confined. There's no further subdivision of PT2. So with that little update, I think I've gone a little bit overboard. I apologize. The presentation is pretty dense with information. There certainly has been a lot of activity going on in prostate over the last decade or so, and we haven't had a really major update in this checklist probably since around 2009 or 2010. So there's a lot of changes and a lot of new information. I would encourage everybody to look at it carefully and to read the explanatory notes. So I think it's time now we can open up the floor for some questions. Julia?
Okay, so as Dr. Srigley said, we are now going to move into the Q&A portion of this session. So there is a chat tool on the top of your WebEx screen. You can click on that and you can type your questions, and then Elaine Maloney here will read out your questions.
Thanks, Julia. From Yasser Al-Gohari, what does it mean percentage 5 in Gleason score 7? If 5, why is it into the total score?
I don't understand the question. If it's Gleason 7, whether it's being referred to it in a biopsy, that would not be the case. It makes sense to me, Gleason 7, because Gleason 7 in a biopsy situation would be either 734 or 743. You could, in a radical prostatectomy, have a 734 or 743 with a tertiary 5 in that text. But I don't understand the question.
As in the context of a biopsy.
See, you would never have a 7. If it was 5 present, it would be recognized in the Gleason score. So it would be, at the least, it would be a 3 plus 5, which is 8. Because see, the rule is that you go by the predominant and then the highest or the worst Gleason score as the next figure.
Okay, the next question is, how to judge if seminal vesicle in the core is not the intraprostatic portion of the seminal vesicle, which in such a case would not count as PT3B?
That's a question, and it's actually much more common to see that situation where you're unsure of yourself. So I think the easiest, I'm conservative about it. If I can't be sure that I'm dealing with the wall seminal vesicle, if I see a little bit of pigmented epithelium that's involved by the tumor that's adjacent to other prostatic tissue, I'm assuming that that's probably still ejaculatory duct or friends or interprostatic seminal vesicle. Because remember, from the point of view of the staging, it's only the extraprostatic portion of the seminal vesicle that's important. So if you have a directed biopsy of the seminal vesicle that's in your specimen, then it makes more sense. So if coming from the seminal vesicle and it looks like seminal vesicle, then it can be reported, and then I think you can be fairly confident that you're dealing with PT3A. I think in the vast majority of cases where you see a little bit of what looks like seminal vesicle tissue, and it's clear if there's admixed prostate tissue anywhere in that core, I would be conservative and not report it as such, and just keep it more general as involvement of seminal vesicle / ejaculatory duct type tissue as opposed to just seminal vesicle.
Okay, any expected drastic changes with the AJCC 8th edition?
I think we just went over the changes, right? Okay. The last slides really dealt with the changes. The changes are basically the getting rid of the sub-staging of PT2-1, including the Gleason grade is endorsed along with the grade grouping, which we've already covered off on, and that for the stage groups, that stage 3, which traditionally was based mostly on atomic extent, now actually includes some situations with where you have patients have organ-kind disease but have high Gleason scores or high PSA values. Those are the 3 things that really the 8th edition changed.
Stage ITC in the lymph nodes.
We deal with, we don't, like if you see tumor in a, you're talking about cells, an IDC, right? Yeah, isolated tumor cells. So isolated tumor cells, we don't really consider in the prostate. I think if you saw them, you would just consider it as an N1.
Thank you.
We don't have the same complexity as in breast cancer.
I have a question from Dr. Wodniarko. Apologies for this name from Health Science North Sudbury. Questions: prognostic of the invasion, grading of post-chemo radiation treatment.
The grading question, that's an important question, so we didn't go into great detail there. There is a field in the Radical Prostatectomy list for whether or not there's a treatment effect or not. And I think that when you do have like neoadjuvant hormone therapy, and sometimes with radiation therapy, you have dramatic effects on the tumor, and certainly, especially with the hormone therapy, it often interferes with the Gleason grading. So in that situation, you can actually include not applicable in category the checklist box for Gleason grading, not applicable because this has had neoadjuvant therapy. Radiation therapy, in my experience, sometimes causes dramatic effects, in which case you can't do proper Gleason grading. In other situations, it doesn't make a whole lot of difference, and you can do the Gleason grading in that situation. But I think the important thing is to include that element of whether or not there's treatment effects present in the in the field that relates to the hormone or radiation or chemotherapy effects. And the other question related to venous invasion?
Prognostic of venous invasion.
Well, I think the LVI venous invasion is unusual to see in radical prostatectomies. I think you're more likely to see kind of a lymphatic type invasion, or sometimes you can't really tell whether it's a lymphatic or a dilated venule. I think I do include that. It's considered an optional element, and as I said, I think there's studies out there suggesting that it's important, and other studies suggesting that in multivariate analysis, that once you know the other aspects of grade, tumor extent, margin status, that it doesn't have independent prognostic significance. I mean, I think it's generally only present in high-grade disease, and I do include it in my reports.
Question from Jeanette Lejoy. How to indicate PT2 plus in the synoptic report?
I think what the thing to do there is it's actually not, PT2 plus is not an accepted term in TNM. That's a term that sort of the pathology and urology community have used, but it's not an official term in TNM. I think the observations of stage and margin are independent. However, I do think having that field in there about whether or not there is, if you have margin positivity and you don't have involvement, you don't have it in the site of the EPE, then by inference it's involving an area of capsular incision. But I think that's a situation where you want to make a relevant comment regarding that sort of type of involvement. And certainly I think urologists are interested in that because that's one of the things that we look at in terms of the metrics, the clinical pathologic metrics at CCO, as we look at the rates of PT2 plus situations. So it's sort of combination of both about the staging observation as well as the margin status observation.
Question from Jay Ramsey. Mesorectum is a QA indicator in rectal surgery. Are prostatic divots or amount of periprostatic fat being evaluated as a QA in prostate surgery?
Not that I'm aware of officially, no.
Okay, and from Patricia Tai, does prostatectomy tertiary pattern of 5, less than 5% versus greater than or equal 5%, a treatment choice later?
No, I don't think so at this point in time. I think what needs to be done is we do in those situations of where we have a pattern 5 that's present as a third pattern, and we just sort of identify the ones that are it's a very small amount, less than 5%, and the ones that are more than 5%. So theoretically, you could have 5 tertiary pattern up 32%, occupying up to 32% of the tumor, as a theoretical example. I think what we really need to have is more data to indicate, what to do in those situations. Should that amount of 5 actually be included in the Gleason score like we do in biopsies? I don't think we have the data yet. I do think it's worthwhile recording that, though, recording that percent pattern 5 in those situations. So that's why we have that field in the new CAP checklist for that purpose. But I think we really need to have more data to understand what's the best way of reporting those situations. Now, those, in my experience, those are relatively uncommon, though.
A question from Dr. Mark Reichenberg. How do you classify a prostate adenocarcinoma with the signet ring cells in the Gleason Pattern 5 component and an Asnar pattern elsewhere? Example, GS9, 4+5 with 10% pattern 5. Well,
I think the signet ring pattern, almost by definition, is a pattern 5. So that would, that would constitute the pattern 5, and I do think that can occasionally be combined with other patterns like 3 and 4. But I'm thinking just sort of included as as if it's truly a signet ring-like carcinoma, not just vacuolated cells. Sometimes you could have vacuolated cells within well-formed glands, or even vacuolated cells within fused or cribriform glands. If it's truly a signet ring-like, where you have, individual cells with infiltrative pattern, maybe with some Indian filing, that would be considered as a pattern 5 definition.
Okay, and I have a comment here from Jay Ramsey that not all labs may include optional synoptic info. If these are important, I suggest that they be automatically included, and I believe that's in reference to a previous comment.
Right. A lot of the issues of structured reporting, at least based on the electronic checklist. When Intuitive implements this, they basically take that checklist and sort of create it into a workable electronic product that can be used and attached to LIS systems, and they do include those optional elements. They sort of don't they don't sort of deconstruct that. They include everything that's in the CAP checklist, whether it's core, conditional, or optional. And I think that maybe some people are modifying that locally. I'm not sure, but I would encourage people to at least keep the option of having those elements in there, because I think they will be important in the future. Remember, it's optional, but there is a level of evidence that is present that indicates that these things are promising for the future, and some of them actually go from optional to core over time, based on studies and clinical trials that are being done. So in addition to the optional elements, there are other elements that people even want to include locally that are part of research protocols, and that really is, that's up to the individual sort of institute or jurisdiction.
Okay, question from Janice Webster. Do you include intraductal carcinoma when calculating tumor involvement percentage?
Great question, fantastic question. So in a situation where we have IDC, obviously you wouldn't include it if it was just IDC, but if there's IDC plus invasive disease, especially in a setting where you have, the usual setting where you have a lot of high-grade disease, I do include the IDC as part of the extent measurement.
Okay, so that appears to be all of the questions. So thank you, Dr. Srigley. So we're now going to close this session. If we could have Dr. close this CAP session.
Thank you. On behalf of the Canadian Partnership Against Cancer, Cancer Cure Ontario, and the Canadian Association of Pathologists, I'd really like to thank Dr. Srigley for a great presentation today. As a reminder, both live and recorded presentations are eligible for continuing education credits. In order to request your certificate of participation, please provide your name and email address at a link included in the session notice. Here you'll also find an optional session evaluation for which we encourage you to complete. The information collected through the session evaluations allows us to ensure that these sessions continue to be informative and relevant to your practice. We appreciate your feedback and suggestions. See the session notice for more information. The sixth and final session of the 2017 series of CAP Cancer Protocol presentations, and we'd like to thank you for your participation in the sessions over the past few months.